Chairman Wyden, Ranking Member Crapo, and members of the committee, thank you for holding this important hearing on the pressing issue of drug shortages. My name is Alan Cockle. I'm a pharmacist by training, and I lead public policy for Civica, also known as Civica RX. Civica is the only pharmaceutical company established especially to address drug shortages. It was founded by a group of U.S. health systems and philanthropies who, after a decade of shortages, realized that the market is not self-correcting and that a different approach is required. They created Civica as a nonprofit with a mission to deliver a safe, stable, and affordable supply of essential medicines to U.S. patients. In our first 5 years of operation, our hospital membership has grown to 1,500 hospitals. We have 80 drugs now with nearly 150 million vials delivered. And with U.S. government support, we've built a state-of-the-art injectable drug manufacturing facility in Petersburg, Virginia. Civica drugs are not chosen for their return on investment. They are chosen by hospitals because they're in shortage or at risk of being in shortage. They tend to be old and low cost, but absolutely essential and used in every hospital every day to treat patients. Because of our mission, Civica does some things differently from the traditional generic drug supply chain. For example, we enter long-term purchase and supply contracts that add stability to the market. We maintain a 6-month buffer inventory of every drug to ensure continuity of supply. We also emphasize U.S. sourcing whenever possible, with the EU and Canada as our next choice, and we don't source from China unless there's no other option. To reduce the risk of a failure to supply, we perform an intensive quality audit of potential suppliers and ongoing quality reviews. And every drug is sold at the same price to any purchaser. The success of the approach has been proven. In fact, 20 of our top 25 products are currently in national shortage, and yet we're supplying member hospitals without interruption. When a tornado hit a generic drug manufacturing plant in North Carolina a few months ago, we immediately let our member hospitals know that of the 21 drugs we have that overlap with drugs from that facility, we would be able to supply double their committed volume. And a recent peer-reviewed study found that supply through Civica is not only more reliable than conventional sources, it also produced net cost savings. So the resilience of this model points to steps that this committee could take to prevent future drug shortages. And make no mistake, shortages are not a passing storm that will soon blow over. After a dozen years, they must now be understood as a built-in and permanent outcome of our current system. The U.S. system is designed so that purchasers of drugs are incentivized to choose the lowest price, saving pennies on already low-cost products, instead of purchasing in a way that makes shortages less likely. Civica's member hospitals have already taken steps to shift the equation, but many others have not, and without action, things will get worse. The immediate cause of most shortages is quality problems in the manufacture of the finished dosage form. But the root cause, as we've said, is low prices. And to put that in perspective, a vial of sterile injectable medicine typically costs less than this cup of coffee that I bought downstairs this morning. So this reduces the incentive of manufacturers to invest in quality or in newer manufacturing facilities. And low prices push production offshore to low-wage markets where quality problems proliferate and the FDA presence is less consistent. Finally, it takes time to ramp up pharmaceutical production. So when one manufacturer leaves the market, we're facing a shortage even if there are other manufacturers that already have FDA approval to make that drug. So policy responses to reduce shortages should include measures to incentivize or encourage providers to contract for adequate buffer inventory, purchase from manufacturers that are less likely to have quality failures, and enter long-term contracts that bring stability to the market. We also encourage Congress to work directly with manufacturers to create an insurance policy. For the cost of about $4 million a drug, Congress can ensure that we have backup domestic manufacturing capacity ready to go when a shortage starts. And how smart would we feel today if 5 years ago we'd made this investment in cancer drugs and we were prepared for the shortages we're experiencing now? A timely investment will provide a cost-effective insurance policy for the future. Thank you again for your attention to this topic and for the opportunity to be here, and I look forward to your questions.